Okay, so common interventions in labor. This is the big scary, all these things can happen talk. I don't mean for it to be scary. Think of these things as tools that you can use to have your baby if you need them. I don't expect any or all of these things to happen to you, but we do use them. And even if you have not seen them before, your midwife certainly has, and they will be beside you every step of the way. A big part of coping with a change in your birth plan is understanding. So listen on and know that you are strong and that you will do great. How I am going to structure this talk is by starting off with the little tiny interventions and changes and working my way up towards the more dramatic ones. So we're going to start with intermittent auscultation versus electronic fetal monitoring in labor. In an uncomplicated labor without risk factors, intermittent auscultation with a handheld Doppler, like what we use to listen to your baby in the clinic, or a fetoscope is the gold standard for assessing your baby's health in labor. Your midwife will listen after a contraction every 15 minutes in active labor and every 5 minutes when you are pushing. Intermittent auscultation allows you to move freely in labor on land or in water. It shows no difference in outcomes of neonatal well-being and is known to reduce interventions in labor like cesarean sections when compared to electronic fetal monitoring. Intermittent auscultation can be used at home or in the hospital. Electronic fetal monitoring is a method of listening to a baby's heart rate continuously and comparing it to the pattern of contractions. This is recommended only when there are increased risks in the pregnancy or labor, such as oxytocin use, meconium in the amniotic fluid, infection, abnormal bleeding, elevated blood pressure, vaginal birth after cesarean section, or preterm labor. Electronic fetal monitoring may also be recommended if your midwife is hearing abnormal heart rates on intermittent auscultation. EFM, for short, consists of 2 paddles that are strapped to your belly and wired into the computer. Sometimes we have a wireless set available to us that allows you to move more easily. Occasionally, if we cannot pick up your baby's heart rate reliably and your water is broken, we can use a small probe that we place in your vagina that clips to your baby's scalp. You do not need to be in bed if you have external electronic fetal monitoring going. You can be on a birth ball beside the bed or walking around the bed, but you have to be tethered often to the computer, and so your movement is somewhat restricted. EFM is also only available in the hospital, so if there is an indication for electronic fetal monitoring in your labor, either identified prenatally or during your labor, and you are not in the hospital, that is a reason why we would move in. Next up, amniotomy. This is the term for when your midwife breaks your water for you instead of it breaking on its own. Only about 8 to 10% of people have their amniotic sacs break before labor starts. For most people, it will break spontaneously when your cervix is between 7 to 10 centimeters dilated, or your midwife will offer an amniotomy. This is also a standard part of an induction of labor. Why we offer it is because having your water broken by your midwife can shorten your labor by 1 to 2 hours, and most people like that. It is a fairly low intervention. How it happens is during labor, your midwife will do a vaginal exam to check that your cervix is dilated enough and that they feel the baby's head down in your pelvis behind the bag of water. It is also important to make sure that there are no blood vessels or umbilical cord felt, as a cord prolapse or a ruptured vessel is an emergency. So once that's ruled out, your midwife will assess the baby's heart rate. Amniotomy is best done during a contraction, as the power of your uterus brings the baby's head down more and bulges the amniotic fluid forward. Your midwife uses their internal hand to guide the amni hook, which is a long, blunt plastic tool with a nick on one side, to release the amniotic sac and the water behind it. They will leave their hand in place to make sure that the baby's head comes down nicely onto your cervix. They will then assess the fetal heart rate again and the color of the fluid for meconium. Breaking your water does not hurt you or your baby. It is like cutting hair. You will feel a slightly longer vaginal exam, and then hopefully your contractions will pick up in speed and intensity. Now let's talk about meconium. So meconium is kind of similar to a bowel movement that a baby has, but it's not digested material in the same way that you're thinking stool that's made from food. Mostly it consists of bile, amniotic fluid, mucus, and cells. Babies can pass meconium before they are born, but they pass most of it in the first few days of life. Babies only make meconium before they are born, and then when they eat, they work on creating their newborn stools. Meconium in the amniotic fluid is common, especially if you go past your due date, as babies are often ready to pass it by then. 96% of babies born through meconium-stained fluid are healthy and well. However, a small number of babies pass meconium before they are born as a reaction to a change in their environment, such as the placenta not working as well as it needs to, or not coping well with labor contractions. Sometimes, these babies also breathe in the meconium and it can settle in their lungs and cause difficulty breathing after they are born. This is called meconium aspiration syndrome. Because of this small population of babies who do not cope well with the meconium, if you have this present in your amniotic fluid, it is an indication for us to recommend electronic fetal monitoring for the rest of your labor. This is to help us differentiate between a baby that's totally fine and a baby who's not coping very well. The chances of your baby having meconium aspiration syndrome are small, about 2 to 5 in 1,000. If your baby passes meconium in the fluid, at our hospitals, it's also protocol to call the team in for delivery. I'm going to talk about the team a bit later on in this video, but between meeting the team for delivery and the electronic fetal monitoring, if you do pass meconium in your fluid and you are at home planning a home birth, then it is a reason for us to move into the hospital as well. IV hydration is next up. Sometimes your midwife may recommend giving you an IV in labor. An IV is inserted into your hand or forearm with a needle, leaving a small, flexible plastic tube in place and hooked up to a bag of fluid. This fluid goes right into your bloodstream and can be important if you have an epidural, or if your midwife has any concerns about fetal heart rate, your bleeding, or temperature. IVs are also an effective way to give you medications like antibiotics, oxytocin for inductions, or just in general keeping you hydrated. They sting and sometimes you may bruise afterwards. Your midwife will be super gentle. All right, epidurals. So epidurals are great for pain relief when you need or want them, but they can also be used as an intervention if your labor is not progressing as quickly as we expect it to. Sometimes an epidural may be recommended for you if you are exhausted and your contractions are not as strong because of this. Sometimes therapeutic rest is what your body needs to have a vaginal birth. Other times, if your baby is not in a position that allows for descent through the pelvis despite all the lunges you have been doing, or if your muscles are tensing up and holding your baby high, then an epidural relaxes the muscles in your pelvic floor and can facilitate descent. It is a tool to be used, just like all the rest of these interventions. There is a time and a place where it can be used to help your labor progress. Take a look at the pain relief video for more information on epidurals. Cervical ripening is the next one we're going to talk about. So if you happen to need an induction to get your labor going, which we'll talk about next, sometimes you need to ripen your cervix first. When you are not having a baby, your cervix is long and closed and pointing towards your spine. As your body gets ready and starts going into labor, it comes forward, shortens, thins out, starts to open, and get ready for contractions. In order for inductions to be successful, we need to mimic the process the body would go through naturally. Your cervix will be scored according to a Bishop's score, and if it is below a 6 on this score, you likely need something to help prepare your cervix for your induction. This requires a consult with an obstetrician. They will assess your cervix, and based on your clinical history and presentation, they will recommend either ripening it with a medication called a prostaglandin, or with a catheter that inflates a small balloon in your cervix, called a Foley catheter. This is often done as an outpatient procedure. Once your cervix is soft and open enough, you can be admitted to the hospital. Sometimes it takes a couple of doses of medication and trips to the labor assessment unit before your cervix is ready. Other times, it can just nudge you into labor on your own, and that's great. It's really common to feel crampy when your cervix is being ripened, so make sure you have your early labor comfort measures ready. which leads me to oxytocin induction and augmentation. So an induction is when we are creating contractions for you from scratch, while an augmentation is when you are already in labor, but you just need a little extra oomph to help your labor progress. We use a synthetic version of oxytocin, which is the hormone your body makes to cause contractions. It is given to you in tiny amounts through an IV, and we increase the dose incrementally until you get a good pattern of strong contractions. You have your electronic fetal monitors going and the IV, so between those two you can feel a bit tethered, but your midwife will help you move as you need to cope with the contractions. You are more likely to want an epidural if you have an induction because it's often a longer process and you can't move as easily as when you didn't have the oxytocin, but it's always up to you. Oxytocin also increases your chances of needing more interventions in your labor like vacuum, forceps, and cesarean section. However, please keep in mind that you are still much more likely to have a vaginal birth than not, and if oxytocin is being recommended, it might be the tool you need to have a vaginal birth. You may be swollen after you have your baby with oxytocin, for example, in your feet, as you will have IV fluid in labor, and oxytocin can cause you to retain some fluid. Intrauterine resuscitation is the term used for techniques your midwife uses to help correct an abnormal fetal heart rate by increasing blood flow to your baby. It might consist of starting an IV or giving you a bolus of fluid if you already have an IV. They might do a vaginal exam, and they might ask you to move from one side to another, sometimes a couple of times. Moving may be difficult, especially if you have an epidural, but if your midwife asks you to move quickly, do your best. They will help you. Assisted vaginal delivery refers to when vacuum or forceps are used to assist you to have your baby vaginally. Your baby needs to be low in the pelvis and your cervix fully dilated. An OB will be consulted with to do the procedure. Sometimes this is done when we are not seeing progress despite all your hard work pushing, like for example, if your baby's head is tilted or facing in a direction that's making it harder for you, or if we are seeing signs in your baby's heart rate that they are not coping well with pushing. A vacuum is a small disc or suction cup that is attached to the baby's head. Forceps are two metal tongs that are placed in the vagina alongside the baby's head. I have videos about both of these in the description. Vacuum delivery is often more gentle on your tissue, but it can give the baby a suction bruise on their head. Forceps are less gentle on your tissue, but usually only leave little small red marks alongside the baby's face. Both of these impacts to the babies often resolve in a day or two, but increased bruising can lead to increased jaundice. I find that with assisted vaginal deliveries, they can sometimes be overwhelming for people because when you are pushing, you are working so hard and it's a vulnerable space to be in, and then all of a sudden the room goes from having you and your support person and your midwives to also having the OB, 2 nurses, and the pediatric team for the baby. It's this change in environment that can be scary if you don't expect it, not the vacuum or the forceps themselves. Just know that everyone is there to support you and your baby, and you will soon be done. Just as quickly as everyone comes into the room, often everyone leaves, and you can catch your breath. You still have to work hard to push with vacuum and forceps. You should be proud of yourself for being so strong. Shoulder dystocia is an emergency that happens when a baby's shoulders get stuck behind the pubic bone as they are being born. The risk of shoulder dystocia increases with very large babies and with gestational diabetes, labor induction, epidural use, and assisted vaginal birth. However, sometimes it can happen without known risk factors. It's really important for your midwife to help the baby out in a timely manner to reduce the risks to you and your baby, like lack of oxygen for the baby and postpartum hemorrhage for you. Luckily, we have some very effective maneuvers that help open the pelvis and release the anterior or top shoulder. Your midwife will lay you flat and help you lift your knees towards your armpits and give you very clear instructions about when to push and when not to push. They will also call the pediatric team and the OB in for assistance with the delivery. So let's talk about newborn resuscitation and the team. About 1 in 10 babies requires some kind of jump start after birth to help them breathe on their own. Usually, this is some gentle rubbing with a blanket and stimulation. Sometimes they need a couple of puffs of room air with a bag and mask, or some suction of their mouth and nose to clear them out. Rarely, babies require a more extensive resuscitation with oxygen and chest compressions. Your midwives retrain every year in neonatal resuscitation so that they are ready to provide it to any baby that needs it at home or in the hospital. If there is an increased chance of your baby needing a more extensive resuscitation, we make sure you're in the hospital and we call the team to the birth. For example, they will be called if you have meconium in your fluid or if you have an assisted vaginal delivery. The team consists of a pediatrician, a NICU nurse, and a respiratory therapist. One that a lot of people worry about are tears and episiotomies. So the majority of people have some kind of tear with a vaginal birth. There are 4 kinds of tears. The first degree involves the skin of the vagina and perineum. Oftentimes, first degree tears do not require any stitches. It's kind of like when you skin your knee. It heals just fine, but it can sting a bit. A second degree tear involves the muscles of your perineum, which sit kind of behind or below your vagina. These often do require some stitches. Third and fourth degree tears involve your rectum and anus. Luckily, first and second degree tears are by far the most common. Your midwife will make sure that you are frozen and will do any repair that is required with a dissolvable suture material. If you have a third or fourth degree tear, because this involves an internal organ, you need a surgeon and we will consult with an OB to do the repair. You can help reduce your chance of tearing by doing perineal massage in pregnancy. I have linked a really great blog post and infographic about perineal massage in the description. Your midwife will also help to protect your perineum by helping your baby's head slide slowly over top of that body of muscles. Your midwife will instruct you to listen to their voice and give tiny little pushes to allow your tissue to stretch. Sometimes your midwife or obstetrician will request to cut an episiotomy. This is where we use scissors to cut the perineal skin and muscles, usually at an angle to the right side from the bottom of your vaginal opening. Episiotomies are not routine care, and we do not do them unless there is a need to expedite the birth and the baby's literally right there on the perineum. Reasons could include a drop in your baby's heart rate right at the end of pushing, or in order to reduce the chances of you having a third or fourth degree tear, like during an assisted vaginal delivery with vacuum or forceps. If we know a few minutes in advance that an episiotomy is likely to be used, and you do not have an epidural, we will give you local freezing right beforehand. Afterwards, you'll feel a bit more bruised with an episiotomy than with a natural tear, but it's usually a straightforward repair and it does heal quite well. All right, so you had your baby. That's awesome. Now we need to manage the third stage of your labor and the bleeding postpartum. After you've had a baby, you also need to have your placenta. Your uterus contracts and the placenta detaches, and then your uterus has to continue to contract to expel the placenta and close off the blood vessels that supplied your baby with oxygen and nutrients. It is normal to bleed as this happens. A postpartum hemorrhage is when you lose more blood than is normal during the first 24 hours after birth, with most occurrences happening in the first 4 hours. The risk of postpartum hemorrhage worldwide is about 5%. For clients in midwifery care in Ontario, we sit a bit lower at just above 3%, I believe. If you have an increased risk of postpartum hemorrhage, your midwife will recommend active management. This means giving you a dose of oxytocin right after your baby is born, either through your IV if you have one, or with a needle in your thigh. This reduces the chance of extra bleeding by 60 to 70%, so it's quite effective. Risks of uterine bleeding, excessive uterine bleeding, include fibroids, a super quick labor, high blood pressure, oxytocin use in labor, or a very long labor. If you do not have any risk factors in your labor, you can opt to request oxytocin management anyway, or your midwife can give it to you if the bleeding is heavier than anticipated. If your bleeding is not controlled by oxytocin, you may be given some other medications. Your bladder may be emptied by a catheter, and you may be given an IV if you don't already have one. Your midwife may also rub your uterus through your belly quite vigorously or do a vaginal exam to check for clots in your vagina. Your iron levels will be checked after 24 hours, and you may feel extra tired as you recover from your birth. We do have all of the things we need to manage a postpartum hemorrhage at home and in the hospital, But if you are at home and your postpartum hemorrhage is not managed by the things that we have in your home to deal with the bleeding, then we would be transferring into the hospital by ambulance. All right, so cesarean section. Save the big one for last. I guess chronologically I could have put this one before postpartum hemorrhage, but either way we're talking about it now. So for most people, having an emergency C-section in labor is a big fear. What I want you to know is that for most people, an emergency C-section simply means unplanned. Your midwife often has time to let you know what they are seeing, why they want to involve the OB, and where they think this is headed. You then meet with the OB, they give you their recommendations. For example, your baby isn't tolerating the oxytocin contractions, or your labor simply isn't progressing despite our best efforts and both you and the baby are getting exhausted. At this point, the best option to avoid an emergency may be an operative delivery. You meet your nurses, we move into the operating room, you get pain relief if you don't already have it, a catheter to keep your bladder out of the way, and then once you are all set up, your partner comes into the room to be by your head. Your midwife is there the entire time. The operation itself to get to the birth is quick, maybe like 15 minutes or so. You may feel nauseous because of the medications. The anesthetist is right there to help you. You will feel some tugging, but no pain. Once your baby is born, they are checked out on the warmer by your midwife and the respiratory therapist or the team. And then as long as they are okay and you are okay, we do skin to skin in the OR while they close up the muscles and skin, which takes a bit longer. Afterwards, you go back to your room and your midwife will help you to get feeding established. You will be under OB and nursing care until you are discharged from the hospital in 2 days. Your baby usually remains under midwifery care. Recovery takes longer from a cesarean section than a vaginal birth, as you just had surgery and you labored. You will also need to recover from all that hard work. Usually it takes about 6 weeks before you start to feel more normal. You will still bleed vaginally as your uterus still has to close off the blood vessels that supplied your placenta. There are, of course, times when we do have true blue emergency cesarean sections. I am grateful that we have such wonderful colleagues in our obstetrical team that can perform life-saving operations when they are needed. They are rare, but they do happen. If there is an emergency, you might be put to sleep under general anesthesia as it is quicker than getting an epidural or spinal. On the other side of the spectrum, some people have planned cesarean sections. For example, if your baby is breech, these are usually pretty relaxed. You get a pre-op package with instructions, show up at a designated time, meet your team, your midwife shows up before the operation, and then you go and you have your baby. Please check out the video on vaginal birth after cesarean section for more information on your choices for having babies in the future if you do have a C-section. Okay, so this is the end of my common interventions talk. Please remember that needing any of these tools does not mean that you were not strong enough or that you could not do it. It means that you made choices and used what you needed to in order to safely have your baby. Take time after your birth to process. Sometimes you will be super proud of yourself. Sometimes you may feel scared of certain parts or sad if something didn't happen as you had planned. Leave room for all of these emotions as they are equally important. Your midwife is there to talk to you. And honestly, this goes for if your birth goes exactly as you had planned it. Sometimes there will be something that sticks in your mind. Just leave room for it, process it, and talk to your midwife as you need to.